So we're back with another episode of Earnest Medicine. I have to tell you, we've been working with Carlos Fenwick, who you've seen actually on the podcast previously, and he is an organizational guy. And I can't tell you how important that is when it comes to defining a workflow.
Yep.
Having him as a part of the team, as the communications officer, has made a night and day difference between our ability to fluidly bring people in for this podcast and even doing field stories. So I just want to give a quick shout out to Carlos.
Oh, yeah. Shout out. And I had the pleasure of calling Carlos's voicemail. It was by far the highlight of my day, just listening to his voicemail message for people to leave a voicemail for him.
Yeah.
It is hilarious. Maybe we'll capture that at some point. But
Excellent.
Well,
we have an individual here from California, and we're going to let him do his introduction right after we roll our intro. But I'm very excited for this because this is someone who I feel is really pioneering a lot of technical innovations within the medical space, which is something that is desperately needed. We have an abundance of technology right at our fingertips, and so often it feels like we're really not utilizing that to our full potential. And especially when we look at what's going on in the United States with our healthcare system, what better place to put that kind of energy and those kind of resources? So let's roll the Earnest Medicine intro, and we'll jump right in here with our guest. All right, so we're back. We're going to turn it over here and let this thing roll. So here's our guy.
Hello, everyone. My name is Uli Chettipally. I'm calling from Burlingame, California, which is the San Francisco Bay Area.
Very nice.
I am the founder of Innovator MD. I also have a startup called Sirica Therapeutics. I'm the founder and CEO. So it's a pleasure to be here, Ernest. It's great to talk with you and your audience. And I should say that you have a great technical team, and they made sure that everything looked and sounded perfect.
Well, it's important. What we're trying to do is capture stories, and we want to be able to do it in a way and share experiences, because that shows the interconnectedness that we have with each other. And the hope is that as we evolve this, that more and more will come into this and this experience, and we can expand more and more stories. The idea is that over time, it will then plant seeds to be able to grow different, thoughts, different approaches to life experiences, not just in medicine, but healthcare, but everything, health, wealth, everything. So, I always like to start with kind of who you are, where you've come from, where are the motivations for what you do, and then we can go into further depth of what you are actively engaged in and the why of what you are doing.
Sure. So my background is I'm an emergency physician, and I also trained in epidemiology, have a master's in public health from UCLA. And then when I was looking for my first job after residency, my mentor told me that I should look at Kaiser Permanente because that is the future of medicine. And this was many, many years ago, almost 30 years ago.
How things change.
Things have changed, and things, I think, for Kaiser are going in the right direction. Right now, it's a pretty solid organization. But at that time, it was a very challenging period for value-based care. So with my background, I got into emergency medicine attending job, but also soon became the chairman of the department because of my other population health and epidemiology background. And it was an interesting job. And after several years, I realized that, this is not the right fit for me. And I switched gears.
Okay.
And started getting interested in technology and living in Silicon Valley during the dot-com boom and bust times. I took a year sabbatical, and did a startup. That's when, building those technology tools kind of taught me that, wow, there's so much more, these computers can do for us, and how can we, implement those in healthcare. And I came back after my sabbatical and got into research, mainly because that's where I felt that technology can be very useful, not only for the company but also in general. So I co-founded a group called the CREST Network within Kaiser. These are emergency physicians, scientists who wanted to do some interesting research. And I was the technology lead for the group, and I created the platform, built the platform, and implemented it in 21 hospitals. And we ran clinical trials, published 100 papers or so out of that work. And right now it's running great. About 1 million patients go through the system every year. And that's my claim to fame.
Yeah, that's your legacy. Yeah, I mean, you started off.
Yeah.
Yes, and that's very much a part of why we're having all these stories is, what are we working on? What are we working on individually, but collectively too? So,
yes.
Yeah. So tell me, but let's go back even further. Why a doctor? Why did you become a doctor?
So I was growing up in India, and there are only two options, when you want to, get ahead. One is either become an engineer or become a doctor.
Okay.
And so my choice was obvious, because I was not good at math. And so I went into medicine, but soon realized that, that kind of brought my passion forward of helping people, and not only in a one-on-one fashion, but how do you create a system of caring? How do you create this knowledge of caring that is ultimately going to help the patients? And that was my passion when I first started into medicine. But as soon as I got my feet wet in the technology side, I realized that technology is a great tool to be able to do that. And I read about it. I implemented a lot of projects, and kind of understood the power of it, on how it can change behaviors of patients, not only patients, but physicians too. You can actually change behavior and make it a better experience, better quality, and better cost.
So in a sense, you are a physician engineer. I mean, I hate to say it, but you kind of did both because you're engineering healthcare in a sense.
Yeah, in a way, yeah, exactly. I don't code or I don't do the math part, but on the design side, yes, definitely. I can design tools and technologies that can help better health outcomes. One of the things that I saw was the glaring lack of evidence for a lot of things that we do in healthcare. And so that was one of my passions, where I wanted to see how can we drop the things that are not working for patients and use the things or build on things that are working for patients. And how do you use technology to identify these two areas? That was a big I guess the central theme of my work there at Kaiser.
What was your education like? Obviously, I mean, did you train or get your education here, or was that back in India?
So I went to medical school in India and came here to Los Angeles, and I was on a research fellowship, NIH research fellowship in hypertension.
Ah, fantastic.
And yeah, that's where I was introduced to the American medicine, and I thought, maybe I can make a difference here as far as research is concerned. But eventually, it took a wide, scenic route that eventually ended up in research again.
Yes. Well, I mean, that's part of it. And what would you say? I mean, now you've been in academia here in the United States in training, residents and medical students. Is there anything that you would say with regards to your training back in India or education back in India in medical school that maybe you see some differences, maybe some peculiarities about it that might be helpful for people to understand?
Sure. So the Indian system is based on the British system of medicine. And so most of the books and the methodologies, we follow the British system. And it's more hands-on type of medicine, where physical examination is everything, not necessarily relying on, tests or, or X-rays or things like that, mainly because, one of the things is that's what we were taught, but also, with the resources, there were not enough resources to be able to run, all these tests that we think would be useful. So you have to rely a lot on the hands-on training and the experience that you gain from, clinical medicine. So clinical medicine was very, very important part of that. So when I came here, I realized that, I had this advantage of knowing the clinical side of it, even though, and then I had to learn the other side, which is the data side and the technology side. So it was a good mix, and it definitely gave me an advantage when it came to, patient care.
That's fascinating. I mean, that's part of the thing that we're trying to understand is because physicians come from pedigrees, and that's from their medical school, their education, and that guides kind of what their, life story as a physician is. And I think I've been fortunate enough to have been able to travel and see and learn more about other practices in Cuba in particular had a foundational effect on me as who I am today. And it's, one of the things we'd like to do is go to other countries. Turkey is one of the places that we're looking at because of their healthcare system and their education. Maybe we'd get a chance to go back to Cuba and those sorts of things. What would be something that we would even entertain going to India too, just because it would be, it would be in a sense to go back to the roots of things. And for myself, that's where the gold lies. That's where you can start to build something, and that building is ultimately your legacy. So with that, we can certainly have this. This story doesn't have to end with this this one podcast. That's where I'm getting at. That's my pitch. We can explore this more if obviously with time and constraints and those sorts of things. Yeah. So from your education moving forward, and then in practice, in a sense, then your observations as a research scientist really helped to lay the foundation for you and what you're doing for innovation. And I think that's, for me, a really strong touch point, because my background was that I actually worked in Building 10 at NIH as an undergraduate in immunology and bone marrow transplant. And there was this, I was always, science was everything, all the way from high school and even beyond. And so I did research for an extended period of time. And I think that made the difference for me compared to my younger medical school colleagues. Not that there was anything better, but it was a different perspective, a different way of seeing things, and a little bit more experiential. And I think is very much why I am and what I do as a physician today. But for yourself, as a research scientist, what are some takeaways about that, because it's a mindset, it's not just, it's a curiosity, right? It is like, can this be done differently? Or what's the root of this cause and effect relationship? But, what would be those things that you would glean and maybe hand off to somebody as your legacy?
Yeah, so one of the things that happened during that period, this is early 2000s, was that, Kaiser became like a paperless organization around 2005, 2006. And so everything became electronically tracked, electronically entered. So all the EHR became, fully active. And for the first time in the organization's history, probably the history of, American healthcare, we had this vast amount of information. Now, how much of it is useful or how much of it is of no use is a different question.
Yes.
But never in the history we had access to so much information about so many people and so many diseases, right? And for the first time, we started looking back to see what is working, what is not working, and it's strange that although there's so many research papers that are written every year and it keeps growing. But that question about what happens to the general population, what happens to, when the rubber hits the road, you have this great research on a drug or a device or whatever, but what happens in actual practice, that is lacking, what we call the real world data and real world evidence. And I feel that there's so much knowledge sitting there, the lot of nuggets sitting there that we haven't had the time nor the inclination to explore yet. And I think that is what is fascinating to me on how healthcare is going to change, not just healthcare, but the knowledge of medicine is going to change over the decade or two, because now we can actually dig out, and find some things. Which until now, we have been doing it because, that's how my professor taught me, or that's how my colleagues practice.
Repeat the same
and
things.
there'll be this new ideas and new thinking around, okay, what is working and what is not. So that is what is exciting to me.
Yeah. I think the fascinating, and I had a conversation, about an hour and a half long conversation about a company that is working on machine learning, people will call it AI, and the application towards the triage, very simple, concept, but vastly complex. And, I think there's, certainly we're seeing this in other fields where machine learning is applicable to things that maybe are simply outside of our scope. And maybe over time, I'm not saying tomorrow that, there'll be Skynet or anything, but I would say that, things, I think have to evolve in that direction just because the data is so vast. And you're right that there's some data that really isn't, the right data. And I think sometimes, as creatures of habit, there are things that we do that need to be improved upon, but it's hard to move that needle in the right direction.
Yeah.
And I think it begins all the way from the beginning, which is education. Going back to education, I think that's a key point for myself, is a sense of, why do people decide to take out a chunk of their life to lead themselves into a profession that is only going to be harder and harder and harder because of the vastness of what you have to do to truly care for patients? It is, you are essentially laying out in your 20s and 30s what your life will be. And physician burnout here in the United States is huge. And the interplay with technology is that there might be a hope that might help. So from your perspective, I would like to, there's that positive of where innovation can come into play and reduce physician burnout and improve outcomes and patient satisfaction and those sorts of things. What do you think are the things that kill innovation?
Good question. So one of the traps that American physician group fell into is that they have to do certain things in order to call it patient care. For example, if you look at our EHRs, or if you look at our history and physical, that's a good example. And we check all these boxes without even thinking, do we really need to do that? Do I really need to know S1, S2 herd? I'm trying to think in my 30-year career when that actually made a difference in a patient's
yes
outcome.
Yeah.
Those are the kinds of things. It's really silly that we keep doing those things, and it's hard for us to step back and see. Oh, do I really need to, check alert and oriented? Yeah, I'm talking with the patient. The patient is giving me history. Do I need to check that box? Right? So like that, there are many, many things that are driven by the system that has been created, because if you don't check the boxes, you don't get paid, or driven by dogma, or that, oh, we have always done it this way, and so we got to keep doing it until I'm done with this job. And so medical science is growing fast, right? It like any other science, it grows. So until we drop things that we don't need, things will start piling up on us.
Oh yeah.
So more and more and more you got to do, more and more you got to learn. And so unless your systems are smart enough to drop the things that you don't need to do, you will keep doing those things, keep adding. So the way I describe it is, a physician is running on this treadmill, and somebody else controls the knobs on the speed and the resistance and the incline. And so they keep running faster and faster, and somebody else is turning up the dial. And that's where the problem is, because the physicians don't control those dials. And they keep running without knowing, where they're going.
Well, if you don't run, you fall off, right?
Exactly. And that is the danger of burnout, where you fall off because you cannot run anymore. Even if you do it at the same speed, after a while you get tired, and fatigue sets in, and then you fall off. So unless you realize that, you'll keep doing that same thing over and over again at a faster and faster speed. And that's where the problem is.
Yeah. Dr. Brown brought up a really good point, and he's brought this up before, but it's talking about how important environment is to the path which you choose. Obviously you had a great mentor who kind of set you on this path to doing house calls.
Yep.
And I wanted to hone in just a little bit on the whole aspect of Silicon Valley. I mean, you were there at a perfect time to sort of be in this hotbed, this motivational hotbed, to push you into this direction of not just medicine, but also innovation and the integration of the two. I was hoping you could tell us a little bit more about the environment of Silicon Valley in that time and how much it affected what you're doing now.
Yeah. So obviously I was I was at a period where everything was going crazy, right? I'll give you an example of when people talk about technology and how it is affecting people's behaviors. Last night I was at UC Berkeley giving a talk to undergrad students about innovation, right? So I looked at my GPS and said, okay, it's going to take about 1.5 hours to go there. It's about, I don't know, 30 miles
traffic.
from my home. I said, okay, I like, face-to-face, meeting people, especially young people, and inspire them. So I said, okay, I'll start, 1.5 hours before. And then, it so happened that, there was an accident, and eventually I went there right on the dot. But, this building is somewhere and the room is somewhere. So I called the organizer and said, hey, I'm in the parking lot. Can you direct me? So she came down, and she's a wonderful young lady. She took me to the classroom. This is a club, innovation club there that they were doing. So there you have the technology part, which is the GPS, right? It worked great until a point.
Yeah.
Until a point, and that is the parking lot. From the parking lot to actually go to the room, it needed another human being to actually lead me there. That's exactly what happens in healthcare, is that there is a role for technology, but there are limitations on how far it can go. And after that, that's where human interaction, the kindness and the spending of time and the healing and all of that, it's a huge part. And that takes place. But if we don't do this part, otherwise I would be running from here or driving from here and going in circles, right? Before I reach the university. And that is where we are spinning in circles because we don't have a GPS. Because we don't have a GPS, we are going on the wrong streets. We're going in the wrong direction, asking people, stopping by. That will take 5 hours if I did that without GPS. But with GPS, I can get there. But from there, you need a human being to actually deliver or reach your destination.
I'm sure there's an app for that.
Analogy.
I'm sure there's an app for that.
Exactly.
I don't know. No, you got to write that down. No. Yeah.
And that's why what you do is so important, that you need that person, that reliable, trustworthy, knowledgeable person that will show you the right direction, right? And obviously the patient has to do their part, but you have to be there as a guide, holding their hand. And that's the beauty of the healing process that happens, right? So to answer your question, being in Silicon Valley, I saw this other part. I know this part, the last half, which is actually, the healing part, where human to human interaction. But I did not understand as much as I did. So what happens is, we as physicians, we tend to stay here unless you're going to research or technology. You don't understand this part. It is so powerful that the systems I design, you can actually change practice of medicine. You can change how long a physician has to spend, or how long a patient has to spend in the ER. Which patient needs to actually be hospitalized. And so those are big decisions, right? How many tests do they need? Whether they need a consult or not. How long do they stay in the emergency department?
Yeah, you're kind of reverse engineering it. Yeah, you're reverse engineering everything. So yeah, with the technology.
Exactly. With the technology, you can answer a lot of those questions where physicians don't have to spin their wheels, but they focus on the actual caregiving part, care delivery part.
I was going to bring up a point that you, Carlos, and myself discussed during the call, and it was with regard to something that I think is sort of mind-bogglingly simple. Honestly, it's almost like a prescription vending machine, if you will, or at least that's how you described it to me. It was this process of going to your doctor to get a prescription, which then is called into a pharmacy where you have to get confirmation and drive there and pick it. Okay, the process goes on and on, right? At least the way that you described it during that call, it was sort of like just this light bulb in the head moment, like, oh, well, why hasn't that been done? Or why don't we see that more often? And I was hoping you could kind of give us a little bit of a rundown about your role in that specifically and how it's being implemented into the care of people everywhere.
Sure, I'll give you a little bit of background. So I started my company, Innovator MD. By the way, I see, Ernest, your role and my role in a similar fashion. You are bringing stories out and propagating them, right? What I wanted to do was wanted to bring innovation out and then propagating it. So we created this platform called Innovator MD. It's a community where physicians and others who have innovative ideas come together, talk about it. Physicians don't have the time, they don't have the knowledge, they don't have the resources or the network to be able to bring those ideas to the market.
Yep.
So what I do is I see about 150 to 200 startups a year, and pick about 40 or 50 of them to come present at my meetings. So out of those, I see something very interesting. If I see something interesting, I put my weight behind it. I kind of join the team or mentor them or, invest in them, as an angel investor. And they're all early stage companies, right? So roughly I invest in about 1 or 2 companies a year, which is very small amount compared to other investors. So I see these nuggets that come out of that. So this company is one of those that you're describing just now. The idea is physicians can prescribe medicines, and in about, I think, 45 states, they can also dispense medicines. Okay. Now, but most people don't dispense medicines in their clinic. Maybe they'll give samples here and there. Some of them do dispense medicines, but not enough of them.
Yeah.
And the reason for that is because it's very cumbersome. You got to figure all these connections from the suppliers, the pharmacy, the pharmacist, the PBMs, and insurance, and how do you keep track, the logs, training the staff, making sure things don't get missing. All of those things are a very complex thing. What if you make the technology do all that work? All you need is a box, a vending machine, which is all automated.
Yeah.
When you prescribe, it goes to the box. A patient can go, check in their ID, and take their medicine and go home right from the clinic or the hospital or the ER.
It's funny you would say that, because in 2009, we had an urgent care. And back in maybe 2008, there really weren't a plethora of urgent cares. But then, now you can get them on almost every other block in minute clinics with CVS. But there was an Indian physician who had exactly what you described. He had a large machine in the waiting area that dispensed medications, which, in urgent care versus primary care. In urgent care, there are very specific medications. So it kind of made sense. But, because there'd be an antibiotic or something that would have a short course. And I just remember walking in and I was like, and then 2 years later it was gone. And I was like, what happened? I thought that would be in, right next to the Blu-ray, the red box video dispensers or those sorts of things. I was like, so I'm curious, and that was back in 2009. So that's quite some time ago. It was ahead of its time. And maybe that might have been the problem. The evolution of technology is such that sometimes it proceeds and then may not necessarily fail. And I don't think it's ever a failure. I think there's an opportunity to learn, and maybe there's a better time. I mean, look, if Tesla had come with his everything with Elon back in like 1990s, it never would have worked. Never. Never. So it's hitting that sweet spot with technology, which I think is important, because it has to require adoption. It has to fit in with things like insurance companies, I mean, you can imagine getting a medication denied by insurance and kicking the vending machine, give me my medications. That would, and then it falls on you and then you go to the hospital. But no, I'm fascinated. Is there a prototype?
They're already selling it. This company, Carbon Health, which is a urgent care kind of chain, newish company.
West Coast based?
Say that again?
Is it a West Coast based entity?
Yeah. I mean, I saw the first installation here in San Mateo County.
Okay.
But yeah, it's working, and they're planning to open 100 new clinics or so, some big number like that, throughout the country. But what I'm saying is that, you know, the technology is there, but more so the need or the market need, and there has to be these right conditions for things to flourish, for innovation to flourish. So it has to be so painful, the problem, that and the solution so simple that, you know, people will adopt it. If the solution is more complex or difficult, people will not adopt. Or if the market conditions are not right, then they will not adopt.
Yeah.
When I did my startup in 1999, oh, that sounds so old. The concept was having a clinic on the internet, a virtual clinic on the internet.
Yeah. Yeah.
It, you know, it had all, you know, some of the components, you know, prescriptions, you know, patient history, you know, payments and appointments and messaging and things like that, all the basic things, but the market was not ready.
Nope. Yeah.
And the technology wasn't ready either. You know, the video wasn't there at that time. And so it took, you know, 25 years for it to kind of become, you know,
well, I remember
a day-to-day thing.
I remember this organization,
So,
HIMSS, Health Informatics. You know, I'm sure you're aware of them, and here in Virginia is kind of the starting point. You know, it was a collection of you know, interested parties and chief technology officers, NIH, and others, and you know, they used to meet at Holiday Inn. And you know, that's where they'd have coffee and donuts. And I remember as a medical student saying, "Oh wow, this is fascinating." And so I'd go. And then fast forward in 2016, I was like, "Oh, there's a HIMSS conference coming on. I think I'll go." And I went, and it was in Chicago. It was the entire Chicago Convention Center, from a Holiday Inn to entire, and it was.
Good bit of growth.
Yeah, it was fast. $1 million displays, little models, hawking wares. I mean, it was kind of creepy at the same time. You know that, you know, it was, and that's where I have to stay close to my roots, which is kind of where yours are too. That it's you know, hands on. You know, when there's a barrier between you and the patient, and I worry about this because. The degree to which I go and help my patients, I will literally pick them up and go to a specialist. I had one who had to go to ear, nose, and throat. And just to, I mean, part of it is to provide my clinical report to my physician colleague, because sometimes that medical education part for the patient is not there or has not been. But then the issue is that, you know, unfortunately, I've had some specialists more recently never even touch the patient.
Yeah.
And it's all EMR. And what I discover is, well, they actually sold their practice and now they are part of a group, which is really business. And they have a practice manager and they have to do this. I think from my perspective, the killer for innovation is the drive for, well, basically greed. The killer of innovation is when, you know, and I think, I don't think it's sustainable. Because if it fails repeatedly. And I think the entry, you know, certainly I understand business and people, you know, the motivations is for profit. But when it stands in the way of medicine should not be a commodity, in my opinion. I don't think patients or physicians should be. I think, you know, there needs to be more advocacy on that end. I think technology is an opportunity to, you know, remove certain elements that are seeking to profit from it heavily. Because I always go back to that same thing is, what is, in India, what is the GDP for healthcare percentage-wise?
You know, I never looked at it.
6
probably 3%.
It's a little higher, but Turkey, it's 4.7. UK, it's hovering around 6. The highest in all of Europe is Switzerland.
Yeah.
And that's, I think, 12%. I think. No, it's 9%, I think. And then you come fast forward to here, and it's approaching 25%. They keep making predictions it's going to be 25%, and it's just like, that's greed. That is pure greed. I cannot accept why that should be that way.
So two things, right? In healthcare, there's a lot of things that we do that are totally useless. And there are a lot of middlemen and middle organizations, middle management that totally not necessary. This pharmacy tool is a great example, right?
Mm-hmm.
All this, thing is not necessary. Is the patient and the physician and the med. So you need a supplier, you need a physician to prescribe it, and a patient who needs it. That's it. There are only 3 pieces there.
Well, I
don't know why it has to cost so much.
Well, they have these graduate master programs in health sciences administration. That's why they have to graduate. They have to graduate and get jobs, and they become administrators. I'm just it is what it is. I'm just poking fun at it. But
So one of the focus for us is physicians need to own it. There's no reason why a physician cannot own this box, which means that you're owning a piece of the pharmacy. Simple.
But physicians don't even own their own practices.
Yeah, that's the scary part. That's another reason why physicians need to own the innovation, because they are the scientific leaders. They understand clinical medicine, and that's our secret weapon. Clinical medicine is our secret weapon. We need to use that to innovate, to make things better for patients. So when you do that, other people cannot insert themselves in there. I'm sure you need investors. I'm sure you need managers, but physicians have to drive that. That's when things get better for the patients and for the physicians too. I think.
Yeah. Life. Burnout. You go to other countries, and we have a colleague that's down in Costa Rica, and he was trained here in the U.S. He moved down to Costa Rica, and he wakes up in the morning, goes surfing, and then goes sees his patients. He's like, I'm never coming back. and we're supposed to go out to Turkey, and my fear is that I might go to Turkey and I might never come back from there.
Never see Dr. Brown again.
I'll be like, see ya.
Adios.
No, that's not true. I'm born and raised here in Washington, D.C., so my roots are here, and it's very much why I am the way I am. And I would say it's how I was raised by my mother and my father, that I just don't accept things. I have a natural curiosity for things, and I don't accept when things are just fluff. I'm like, no, that's not going to satisfy me. It's not going to satisfy what my patients need. So that's in large part, I have no other choice to practice the way I practice if I want to practice medicine. If I want to practice healthcare, then I don't know. I would do something completely. I would do a podcast. That's what I would do. I would do a podcast.
Well, you brought
which hasn't gotten any funding.
You brought up a really good point with regard, to legacy. You talk about being here in Washington, D.C., and at the same time, you also mentioned that doctors don't really own their practices anymore. And you oftentimes have hospital administrators who are in control of these huge facilities, and they're just sort of managing at that point. They're more or less business leaders. They're not really healthcare professionals who even give a hoot about the patient, for that matter. So talking about innovation, but also going back to the roots of medicine, where we were when the doctor, as you've said many times, lived near the hospital, was taken care of by the community.
Owned the hospital.
Yeah, owned the hospital facility, had a real skin in the game for that quality of care for the people who visited the facility. It's almost like we have to find a way to push the needle forward with technological innovations, but also in some ways kind of go back to our roots and really start empowering the people who are administering the care. I feel like that's where we need to be. It's this middle ground.
I think, as a physician, the amount of time you've seen me as I dedicate to my patients, to deviate from that and work on certain other things, even though I know that it would make things better.
Yeah.
My biggest fear is I have missed something for that patient. I can't go to sleep. So my only issue is that I feel, and I think I see this from other physician colleagues, that deviation from that has the risk of impacting patient care. I'm more for the whole model of, if you build it, they will come. I think it needs to come from not consumers, but from those we care for, because they need to advocate. There has to be a way for them to advocate and guide and take ownership, because it is ownership of their own health, the health of their families, the health of their communities. And we know very well when you have a healthy person, a healthy family, or a healthy community, there's so much more we can do. There's this undertone of healthcare in the United States is to treat illness, not to treat your population health. So prevention is everything.
Exactly.
But we don't.
So if the business model is set in such a way that you make money when the patient is sick, of course the patient is going to stay sick. And the people who are greedy, they're going to make money on sick patients, and so they don't have any incentive to keep the patient healthy. And that's where most of our problems start. The business model of healthcare.
Yes.
And if you think about it, imagine, if you go to a hospital and say, hey, I have this piece of technology and it'll decrease your admissions. What would happen? You'll be kicked out.
They'll lead you downstairs into the basement, open up the autoclave, and let you walk in.
Take you out in handcuffs. It sounds like something like that.
So the business model doesn't work. If you have to do the right thing, the business model doesn't support the right thing, because it is so ingrained in the old methods, which is, we make money when you need an operation, when you need a test, when you need a prescription, when you need a hospital, so that is where, and if you think about it, data science, when you look at it, it doesn't work there either. If you really want to use data science, it doesn't work there either. Fee for service will not work. And that's another reason why this technology will not be adopted to the fullest extent. If you want it to be fully useful, prevention is the way to go. You can predict, you can prevent, you can measure things, and that's why you don't measure your outcomes, because you don't want to know what your outcomes are.
You might be a little frightened by the numbers that you get back on those reports.
Yeah,
exactly. And you might have to, change your methods and change your practice
or career.
That might decrease your income.
Yeah, exactly. So, well,
yeah, I think we've had an excellent conversation, and I know, again, we say this every time, but it's really just scratching the surface of things. I know you have a healthy LinkedIn following, people who are really engaged with what you're doing in this space, and I think that's an awesome way to share that message. And I'm hopeful that you'll also provide us with a couple of links to work and other video segments. You shared with me a really interesting VR sort of piece of machinery that you were using online.
I didn't talk about that.
But please, we'd love to hear that segment, because we want to show a clip of that on the video as well.
Sure. So this is more personal because we have a daughter with autism. Autism is a very strange disorder. It is rising so fast, the prevalence of it and the incidence, that there's not enough therapists that can handle them. There's no way. It's every 1 in every 44 children who are born, and now it has overtaken all the other developmental disabilities, and this is the number one fastest growing one. And so, there is the therapist there, that which is one-on-one, whatever, 20, 30, 40 hours a week they have to spend on these kids. And there are these drugs, which are very generic drugs, depression drugs, anxiety drugs, but then they all have side effects. So we came up with an idea, and that is, how about using exercise, a physical exercise and a mental exercise, to help these kids, number one, with behaviors, with aggression, with anxiety, and with sleep problems, where you're exercising very well, but also you're enjoying the whole experience through VR and video gaming. So we came up with a device. Actually, this device was designed for stroke recovery, but we are repurposing it for autism. And my daughter, when we went there, when they first released the prototype last year, we went there and she tried the machine and she loved it. Her name is Siri. So what I did was, we spun off this company, Sirica Therapeutics, where we're going to take that machine, design games specifically that are interesting for people with autism.
That's fascinating.
And use that as a therapeutic device. And so there's some interesting and fascinating work that keeps me busy.
How old is your daughter?
She's 30 now.
Excellent. And do you think she, I mean, it, one of the things is, it's the people who experience this are the ones who are really the ones who can really make it work, right? Because they know.
Yes. So, yeah, definitely. Because what we have seen over the last, several years is that we put her in some intensive physical training programs. And, like circuit training, like boxing, like functional fitness. She does very well and she loves it. And we have seen improvement in her symptoms because of that. And so I was looking for something, how can we put this whole thing into a box or into a machine? And we think that we found that machine. So it's going to be exciting when we actually do the clinical trials and see how effective it is.
Would be fascinating. I can tell
so
you.
I have a video of that I'll share with you later
Excellent.
on.
And I can say, my son, Kayvon, he has a genetic disorder, Klinefelter's. And so he has features neurologically for, executive function disorder, impulse control, and those sorts of things, which has a profound effect such that his peers have certainly outpaced him, and he struggles to be able to, in a day function. And anything, technology-wise that could potentially help him with his executive function disorder and impulse control, can save a life. I mean, it's no small thing. And autism, and especially with the prevalence and incidence for it now, even more so. Otherwise, if you go back in time, I was just talking to a colleague who was describing, when lobotomies used to be the fashion, and institutionalizing, patients. In a sense, we have not moved far from that, because we are providing some services and maybe even diagnostics, but it's, the effective change in their life is not much, over as much as we have.
And the scary thing with autism is that as they get older and then their behaviors get out of control, their world shrinks, and eventually they'll end up on the couch in front of TV. And so all these bad, side effects of inactivity, overweight, and these things, it's really sad to see some of these adults, the way they live. And we think that we can make a difference in their lives with this kind of a technology.
Well, we'd love to come out there too at some point. I know East Coast, West Coast, and those sorts of things. But we do plan on, being able to take this further and walk people through the experience. I know this is a virtual experience essentially, but we are trying to build that over time. And we are actually our nonprofit is in the works to be able to continue to support that. So we would certainly, this is not the last, I would hope, that conversation we have. And I would certainly hope that, we would, as colleagues, and John, you too, jumping in, there might be something, we might be like, let me give him a call, or let's throw this out and see what bites.
Yeah, and I think
Definitely.
the hope is that we can start to engage a community more deeply. I think, as I mentioned in the very beginning of our show, having Carlos as sort of our communications entity, that's such a critical component to what we're trying to do, is telling these stories and sharing practitioner stories, client stories, patient stories, is to find a community of people who can resonate with the messages that we're sharing. And those people are out there. It's just a matter of getting the pieces in front of them so that they can engage with them and then share them with others who are also in that same boat, who want to hear these stories and see these stories on
in an era where TikTok and YouTube, it's so easy to get, inundated with data or, other things.
Dancing
I don't know
cats.
if I'm very dopamine responsive to people, but, I think it's worthwhile to, do these things. And it's, where we are now and where we find ourselves in 5 years. I very much want to think about, I'm 54 years old, and I want to think about, what I'm leaving behind. And, those things are important to me. The beard only proves I'm getting older, so and longer. But yeah, so I think this is great, and thank you so much for your time. I think let's not let it stop. Let's continue to explore at any point in time. And if you happen to be on the East Coast, DC,
let us know.
Yeah, you can actually see the studio too.
Yeah.
Definitely want to check out your studio. It looks cool, man.
Yeah.
I like it.
Excellent.
Yeah. Well, thank you so much for hopping on with us. I think that we are going to kind of end this episode here, and we have more lined up. We're really on a productive cycle right now, and I'm so happy that we're in that phase, because we're hearing a lot of important voices and sharing a lot of important stories. But we're going to tune off for Earnest Medicine on this episode. Thanks everyone for watching. Please like, share, and comment if you can. If you have others in your life or on your socials who are engaged with this kind of stuff, make sure that they are able to see it as well. Share it over with a friend or family member, and we'll see you on the next episode of Earnest Medicine.
Take care, everybody.
See ya.
Thank you. Bye-bye.
And if you happen to find any of this interesting, or more importantly, if you want to collaborate, check out the link below so that you can send us your comments, any stories you may have, anything. We're happy to entertain it. And this is really about us going on a journey together.